Boleh tak tu? Alizan?
Saya dah cuba tapi dia tak nak.
Tapi button share screen tu ada tak?
Oh, jap.
Ni okey? Tak ada. Tapi masih hang. Internet sana tak berapa cantik tu, betul? Dia putus-putus, suara pun putus-putus.
Dapat ke?
Nampak? Tapi suara tak berapa clear. Dia macam putus-putus.
Oh, line tak clear tadi. Sekejap saya cuba tukar
Ni
sabar
okey
line.
sikit. Dia kadang-kadang datang line dia tak berapa cantik, dia akan jadi putus-putus. Ni semua nampak betul? Boleh? Tak apa dengar, sorry.
Tukar ke mic tu dekat mute tu.
Saya belum share lagi.
Okay.
Maria.
Dr. Maria, sebentar ya Dr. Maria. Boleh tak tadi?
Lepas ni saya cuba balik boleh? Sebab saya nak set up sikit.
Jasmine nak keluar dulu ke apa?
Saya nak saya just nak screen saya masih share ke dah tak share lagi?
Dah tak share. Screen dah tak share.
Okay. Tak apa, saya cuba masuk balik dah. Sekarang suara clear ke putus-putus?
Dia kadang-kadang tu putus-putus.
Putus Kalau saya pakai laptop kawan saya boleh? Dr. Nur Syahira.
Yang ni okey, yang ni suara okey. Tapi time bila line dekat situ ada banyak laptop ke on?
Ada 3.
Saya takut sebab tu. Dia berkongsi line tu.
Saya pakai line saya sendiri. Saya tak pakai MPP UKM punya wifi sebab saya punya laptop tak boleh connect tadi.
Okey. So far ni suara okey.
Better lah.
Dia macam putus-putus dia. Dia macam putus-putus.
Masa takut line internet.
Biasa macam ni line internet.
Cuba try yang
sebab ada
nampak.
Tak boleh connect kat saya punya laptop.
Apa try laptop kawan.
Macam yang ni gambar pun dia macam stuck. Sebab internet. Ni terus hang lah. Cuba dulu. Sebab nanti saya ada.
Tak dengar.
Tak dengar.
Saya tak ada cakap apa-apa. Kalau guna option lain pakai laptop presenter lain boleh?
Presenter lain boleh ke?
Tapi nanti tukar nama.
Kena tukar nama? Rename lah.
Rename.
Presenter lain tu siapa tu? Boleh saya tahu?
Yang laptop ada dengan saya Dr. Nur Syahirah dengan Dr. Asfar.
Saya rasa should be no problem lah. Tapi nanti bila moderator sebut nama, doktor yang present lah. Nanti kenalkan lah. Okay, saya Dr. Alizan. Nanti supaya orang tahu lah.
Okay, boleh. Boleh.
Itu kan sama dengan Asfar.
Alright.
Asfar dengan Dr. Nur Syahirah.
Tak apa, pakai je yang ni. Kalau in case tak payah log out, pada saya tak payah log out. Kalau putus-putus nanti kita akan maklumkan, cuba present dekat PC
Asfar
ataupun Syahirah. Tapi make sure download dulu PowerPoint dekat PC dia orang. Supaya nanti tak ada delay. Tak ada baru nak transfer. Okay
Okey, boleh. Boleh.
Alright. Thank you.
Sedar iPhone.
Dr.
Terima
Maria.
kasih.
Sama.
Maria.
Okey.
Okey.
Assalamualaikum. Saya Dr. Maria.
Waalaikumsalam.
Okey, nak share screen.
Boleh.
Alamak, kenapa keluar yang lain pula? Sekejap
Keluar lain. Di, tak payah Di. Sibuk-sibuk Di.
Okey, dah keluar ke?
Keluar lagi tu. Tak share screen. Tak tekan button share screen.
Sekejap. Okey.
Alright. Tapi ni tak full screen lagi. Dr. Maria, betul?
Okey, dah.
Alright. Action.
So, okeylah
Alright.
Okey, terima kasih.
Boleh saya tahu tak siapa lagi yang present yang masih belum test share screen ke? Yang saya tak sebut nama. Afiana ada. Semua dia ada. Belum ni. Boleh? Boleh. Boleh. Alright. Ni ada. Sana dia.
Hello, Assalamualaikum.
Waalaikumsalam.
Saya nak try guna Dr. Asfa punya line. Okey tak?
Ini okey tadi.
Better
Better.
Sekejap
Maria tadi.
Kau punya ni.
Dr. Maria tadi.
Tak ada. Dia voice ada tapi tak ada suara.
Dengar tak?
Boleh dengar. Okey.
Voice pun dengar.
Voice dengar cuma bergema tak?
Dia macam humming, ada humming sikit lah.
Okey.
Tapi okey lah. Dekat dengan laptop tu lah. Tu dekat dengan laptop kan.
Sebab komputer dia pula yang tak ada keluar suara.
Komputer tak ada keluar suara. Dekat earphone tu tak dengar.
Mana kau mute kan? Dah unmute dah.
Function apa?
Dia dekat sini dia tak pair kan.
Dah tak ada.
Dia tak pakai yang dia
Sekejap cik, saya nak configure dia punya speaker pula. Dia punya speaker pula. Sekejap Lepas tu saya contact balik.
Doktor, saya akan mutekan semua guest, dia tak boleh cakap lah. So, memang dah tak boleh. Okay, tak boleh cakap. Cuma
Tapi semua dah ada?
Semua dah ada. Cuma yang saya dah pecah balik. Sekejap.
Okay dah, should be okay. Dah try.
Nora Datul Akmal belum ada ke?
Tadi? Aida.
Assalamualaikum. Tadi saya dah test.
Okay. Nama lain dengan list saya. Orang-orang okay. Okay.
Oh, kau tak pakai tu ke?
Itu tadi.
Ni?
Nak tukar ke nama saya kepada nama penuh?
Tak apa, no problem.
Okay.
Okey, terima kasih.
Hati-hati. Nawara.
Pelanggan yang dihormati, anda dikembangkan suami kerana tidak.
Ya.
Oh, sebab you punya
Minta.
Diorang dah nak start ke?
Sebab Zoom selalu orang boleh hack. Boleh berjaga lebih hack.
Dia ada PC dia.
Assalamualaikum Cik.
Waalaikumsalam.
Dah boleh dengar dah?
Boleh.
Ni Dr. Alizan. Saya pakai Dr. Asfa punya laptop. Saya nak cuba try share screen saya punya presentation boleh?
Boleh.
Sekejap
Dah ni.
dah boleh Sekejap nak buka besar. Mana button dia?
Dia pupuk.
Better ke dia punya line?
Better.
Okay, saya akan pakai PC Dr. Asfa lah. Saya akan perkenalkan diri dulu lah sebelum saya present nanti.
Alright, boleh.
Okay, alright.
Alright. So boleh stop.
Okay.
Stop share.
Okay, saya stop share sekarang.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Dan selamat pagi. So we are going to start our oral presentation for today. So for clinical side. So we have with us two judges, which are Professor Madya Dr. Nani Halina Muhammad Lata from Jabatan Surgery. Okay. And also Professor Madya Dr. Syamsiah Makdin from Department of Ophthalmology. Okay, so they will be our judges for today. So there will be 10 presentations. Okay, so actually we are going to start with Dr. Afiana Rahmani. Okay, so each presenter will be given 7 minutes to present their slides, okay, and followed by 7 minutes of question and answer session with the judges, okay. So when your turn comes, you have to unmute yourself and you have to share your slides on your own, okay. So when the time's up, so we will give the signal, means that you have to stop your presentation. Similarly, when the time is up for question and answer, so we will give the signal for the session to be stopped. Okay, all right. So are you ready to start now? So the first presenter will be Dr. Afiana Rahmani. So the topic is sex determination from measurements of the first lumbar vertebra by computed tomography in the Malaysian population. Okay. So I would like to invite Afiana Rahmani to present her slides. Okay. So you have 7 minutes. Okay.
Okay, Assalamualaikum. My name is Afiana. Can you see the slide here?
Yes.
Okay, my name is Afiana. I am PhD student from Forensic Unit Department of Pathology. Today I'm going to present my research. The title is Sex Determination from Measurement of the First Lumbar Vertebra by Computed Tomography in the Malaysian Population. Okay, for the discovery of skeletal, immediate question that will come in our mind will be, are they human? Or is it male or female? Or how old was the person at death? How tall was the person? What was the most probable cause of death? But of all these questions, the most important aspects for identification of the skeletal remains is sex determination. Because this is an important starting point in any anthropology examination, and by knowing this, by knowing it is female or male, it may be able to narrow down the possible matches by 50%. Several studies have been utilizing a variety of bone for determining sex. However, pelvic bone is the most reliable to use of all bone. This is because the female pelvis is designed as an optimal space for the birth canal, ideal for delivery. But in some conditions, such as mass disaster, crime victims, and advanced decomposition, the human remains may broken, may fragmentation, missing, and commingled. Therefore, it is essential to develop an alternative method using other skeletal elements for sex identification. A few studies have evaluated the vertebra for estimating sex due to their weight-bearing function and relatively density. They may provide a variety of information. Several studies have been reported sex assessment using several types of vertebral bone, even single type or combinations using measurements. However, the validity of these bones for sex determination has not been explored in the Malaysian population. So the aims of this study is to investigate criteria for sex estimation in the first lumbar vertebra to generate population-specific equation for sex identification in the Malaysian population. Method. This study was conducted on 100 patients. 100 patients include 50 males and 50 females, aged between 18 and 75 years old, who presented the radiology department, UKM Medical Center, for multi-slice CT of the abdomen. Only intact vertebra subjects by CT scan were included in this study without any pathological condition. So here we can see these are the 13 linear measurements taken using 3D morphometric software by the same operator. These are the measurements used in the study. You can see here, for example, there are 13. For example, I can mention this. This is the upper end plate depth, and this is the lower end plate depth. This is the upper end plate width, and so on. This is the vertebral body, and this is the vertebral foramen, pedicle. This is the articular process. This is the spinous process, and this is the distance of transverse process. The results. Here is the descriptive analysis of the first lumbar vertebra presented in two groups with sexual differences. So by independent t-tests, there were significant differences between sexes in 8 measurements. You can see here the p-value lower than 0.01. For example, this is the upper end plate width. This is the lower end plate width, and so on. There are 8 measurements. And using the univariate discriminant function analysis, these 8 variables were significantly different in sex, and with the correct sex classification accuracy ranging from 84.1% until 10.7%. And the highest accuracy, you can see here, the highest accuracy was achieved by the upper end plate depth with 84.1%. And here is the Wicks lambda. Wicks lambda was performed to show how well each independent parameter contributes to the model. The scales range from 0 to 1. The closer the Wicks lambda is to 0, the more contribution is the parameter towards the discriminant function. This study performed the discriminant function equation by using the stepwise method. By the stepwise analysis, the combination of parameters that showed the best sex difference was selected according to their discriminating power to differentiate between sexes. This method automatically selects the best discriminating parameters and removes those which are less discriminating. From the 13 parameters, only 3 parameters were selected. They are lower end plate weight, upper end plate depth, and the posterior vertebral body height. So these parameters were selected to be included in the equation with accuracy 93%. So here is the discriminant equation for sex estimation. We can estimate sex by this discriminant equation for the first lumbar vertebra. And the cutoff value of the discriminant scores, the best discriminant between male and female by calculating the sectioning point. We have calculated the sectioning point is 0. Therefore, if the discriminant score is equal or greater than 0, we can classify it as male. And if the value is less than 0, we can classify it as a female. Discussion and conclusion. This study aimed to determine whether sexual dimorphism in the first lumbar vertebra could utilize as an effective sex estimation method. So we can see here there are some studies also using the first lumbar vertebra to determine sex in different population. Zhang et al. 2012 studied in China reported three variables performing discriminant equation. They are.
Okay, Afiani, your time is up actually, 7 minutes. Okay, so now we open for question and answer session with the judges.
Okay, Afiana.
This is the conclusion.
Afiana.
Yeah.
Okay, Miss Nani here. So my question would be, you've got a few previous studies that you quoted, right?
Yes.
And
Yes.
The accuracy is quite good for all those studies that you quoted. All right. So why do you think that in Malaysian population, why do you think that there will be a difference in measurement of these parameters as compared to previous studies?
Well, because in my opinion, Malaysian population is different with the other population. As we can see on here, Chinese is the race. What do you call? The race is different with Malaysian, and also Egyptian and other. Because race in previous studies, race got different morphology, body morphology, maybe including the vertebra, especially the face. The face and the stature is different among population. So that's why I interested to provide in Malaysian population.
Okay, my second question is that can you relate your study findings with what is the clinical relevance of your findings?
Okay, so my finding by using this discriminant equation, we can predict or we can estimate sex by using the first lumbar vertebra, because as in mass disaster or in what you call fragmentation and decomposition, bones are quite fragmented but broken or missing. So we can use first lumbar vertebra to to determine sex, to predict sex, whether the person is male or female.
Okay, thank you.
Ms. Afiana, you pointed out a very pertinent question about this study, in which you highlighted that in Malaysia you have various ethnicities, Chinese, Malays, and Indians. And if you compare with the other studies, they were possibly only in one group of ethnicity. May I know how many categories or how many participants do you have in each ethnicity? How many Malays, how many Chinese, and how many Indians? And have you adjusted this accuracy that you found according to the three major ethnicities in Malaysia?
Okay. Actually, I didn't calculate among Chinese, Malaysian, and Indian. But in my opinion, that these three races are already belongs in Malaysian population. I didn't. Maybe that's the limitation of this research. Yeah, I didn't calculate the Indian, Chinese, and Malaysian.
But in general, from the 100 patients that you took, how many, roughly, I know you do not have the data on whether they're Malays or Indians or whatever, but do you see like majority of ethnicity in your 100 patients participants?
The majority are Malay race. The majority. Yes, the majority are Malay race. Only a few Chinese and only a little bit Indian.
We have a few more minutes. Can you tell us how you get the accuracy of 93%?
Okay.
What's your calculation, or how do you do it?
Okay. What I did is by using the discriminant analysis, the step-by-step discriminant analysis in the SPSS, we able to perform discriminant equation, and it automatically, we can automatically found the accuracy 93.0% by using this discriminant score. Yes.
Okay. No more questions from me.
By using the SPSS, it's automatically.
Okay, Afiana, I think your time is up.
Yes.
Okay. So thank you, Afiana. I think your time is up. 7 minutes finished for question and answer.
Yes.
So you can unmute yourself.
Okay.
Unmute yourself.
Unmute. Okay. Sorry. Wait. Unmute.
Syam, dia kena stop slide share kan?
The recording has stopped.
Okay.
This meeting is
Thank you,
being
Afiana.
recorded.
So we go for the second presenter. So the second presenter will be Dr. S. Maria Awaluddin from JKM. So she's going to present her research topic on a qualitative study exploring challenges faced by parents who were the primary caregiver of children with tuberculosis. So, Dr. Maria.
Thank you, Mr. Chairman. So I want to share the screen. Can everybody see my screen? Assalamualaikum and a very good morning. Yang berbahagia professors, lecturers, MPP Secretariat, and to the rest of my colleagues. My name is Dr. Esmaria binti Awaluddin. I work in Institute for Public Health, Ministry of Health, and today I'm presenting a qualitative part of research on tuberculosis among children. So my topic today is exploring the challenges faced by parents who were the caregiver of children with tuberculosis toward achieving successful treatment. These are my research team members. So my presentation will start with introduction, material and method, result and discussion. So let's we move to the introduction. Okay, this is as introduction. Malaysia is a country with intermediate tuberculosis burden. So please look at the table. Table 1 is a trend of the notified tuberculosis patient in Malaysia from 2013 to 2017. Actually I cannot see, but I want to show this is the trend of notified cases for 5 years, and we can see that TB patient among children is around 700 per year. So and account about the percentage of children with the adult is around 3%. So before I move on, TB patient among children is referring to the age 0 to 14 years of the population. So children cases is fewer than adult because the protective effect of BCG vaccination, and also children have less social contact. However, any cases among children means that there is a recent transmission of tuberculosis in the community, and also it informs us about our control in this tuberculosis. And please look at the figure, the below one. The figure is the 5-year trend of treatment success among children in Malaysia from 2013 to 2017. We can see the red line indicate that this is treatment success among children for the age group 0 to 5 years. Because the younger age have a high mortality rate, and that's why this treatment success is not achieved the WHO target of 90%. So parents' behavior, treatment success actually determined by many factors. So one of the factors is parent behavior. So how we want to measure parent behavior? We can measure using, we can explore using Hillbilly model, and Hillbilly model is a theory. We want to know how human behavior change with regard to the chronic illness such as tuberculosis, and it can help us to explain and predict behavior change. So what are the Hillbilly model have a 6 construct, and one of the construct is perceived barrier. So what are the barrier that parents or the primary caregiver have faced in previous study? So this study was conducted in a country with high TB burden, such as in Botswana and Brazil. So we have a long delay in their child diagnosis, difficulty in administering TB medication, lack of TB education among caregiver. So the objective of this study is to explore parent experience on the challenges in achieving successful TB treatment of their child in Klang and Petaling district of Selangor. So we move to the next slide. This is a material and method. So this study was conducted using phenomenology study design. The study was conducted in Klang and Petaling district at home setting. So data collection conducted for 1 month. Each session took about 40 minutes to 1 hour duration, and it was recorded with tape recorder with consent. So using an in-depth interview based on interview protocol has been reviewed by the list of panel of experts. So we use a tape recorder, and the researcher as the instrument in this study. So it was supplemented with hard copy note during the data collection. So the study population was a parent of children with TB disease. The inclusion criteria is either mother, father, guardian, age 18 years and above, and have a child who with TB disease. The child should have completed TB treatment or still taking TB treatment. And another criteria is the primary caregiver must have involved directly with the children during the illness phase, during the treatment phase, and during the follow-up. So those parents who did not understand Bahasa Malaysia, English, stay in black area, uncontactable, and refused to participate were excluded from this study. So this study, the source of population we get from the registered TB case for 2017-2019. So criterion sampling were used as the inclusion criteria. So the maximum variation sampling is 12. We start with 12 because we want to consider the data saturation theory. Parents were approached via WhatsApp application. So written consent was taken before prior to the interview. Unique identity was assigned to the participant to maintain the anonymity. Data was managed in confidential procedure because only the researcher have the direct access to the data. So data analysis, data were transcribed verbatim. Thematic analysis using the R-based qualitative data analysis under R package version 0.2.8. So validity and reliability were assured during the data analysis. This study has obtained the ethical approval from Research Ethics Committee of UITM and also Ministry of Health with the registration number.
Sorry, Dr. Maria, your time is up. 7 minutes is finished already.
Okay.
So I have to open for question and answer session with the judges.
Okay.
Okay, Dr. Maria,
Yeah.
Can we go to your title again sekejap? Because you punya yang dalam tu dengan yang ni macam lain sikit.
Oh yeah. I think I
don't have in your slide.
This is the title.
Okay. Okay. You sampled caregivers or parents from 2 areas.
Yeah, in Klang and Petaling district.
Okay. Yeah. How do you think that those sampling that you did might affect? How would it affect your results?
Because this is a qualitative study, so I plan to get population which can first logistic for me. I can go to that area and I get someone person in charge in the Klang district to help me to select the participant. So participant in this area, because Selangor is one of the highest state having TB disease, so all cases is registered in the MyTB data. So I think
that you can always get patients from other. You can always get patients from other areas who has children with TB. So how would you better sample your population?
For that one, maybe I need to sample more than location, selecting for the urban and rural area, because we want to get the population from different socio-demographic, so we can get experience from participant with different background.
Okay. Okay, I think that's all from me.
Okay, thank you, Bob.
Dr. Maria, we can only comment on the 2 portions of your presentation, which is the introduction and methodology, because you have finished your time before even going to the results. There's a few questions to ask. So your title is Exploring the Challenges Faced by Parents in Ensuring Success of TB Treatment. How do you define success? Because you do not put that in any of your slides so far. And the second question is, why do you exclude parents who stay in black areas? Do you have some discrimination against them, or do you think they could not give a valid data? Why was why were they excluded?
Okay. The first, thank you, Prof, for the question. The first one is
the first one was, how do you define success in treatment?
Success. That one is according to the WHO guideline. We have a definition, a standard definition to define success. Success is the children who completed the treatment and having a cure, meaning from the tuberculosis Putem's positive, it changed to negative and completed the treatment for the required treatment of 6 months or either more than that, according to the diagnosis. For the second question, why that parent is excluded? Because I'm a student, so I'm conduct this study is alone. Actually, we want to know the experience from them. However, because of black area is dangerous to the researcher, so we need to consider that into my study. So this is qualitative some more. So qualitative, we need a very cooperative participant. If they is a not qualitative, not cooperative, we cannot get data. We cannot get data from participant.
Okay, so you define success in treatment as completed treatment or cure.
Treatment.
Okay? But you included both who have not completed their treatment and those who have completed their treatment. Why is that so?
Oh yes, because I don't actually, the aim is to get from the completed treatment, because I don't, the response is very poor actually. I contact about 43 participants, but only 15 mother respond to my, so I have to include the 3 participants who not completed, just to get the idea how they start the treatment, how they experience on the starting the treatment, the illness. Did I answer the question?
Yes, but then if you have 2 groups, right? One who have not completed treatment and one who have completed treatment, how would you use those data to answer these questions that you have, like exploring the challenges? How would you use both groups of study treatment?
That one, because this is a explorative study, so the result is presented with thematic analysis. So it is nice to have experience from those who unsuccess. But because of my study is looking onto the success, so this study only looking at the experience of parents who had success. So I think we need to conduct another study to explore on the unsuccess parents.
Yes, it would be good if you have 2 groups of patients, one who and one who are successful, and you look at the reasons why they are not successful. So that would actually answer your question better. Thank you.
Okay.
So I think the time is up. 7 minutes finished for question and answer. So thank you, Dr. Maria, for your effort. Okay. So we should proceed to the next presenter, which is Dr. Nur Aniah Azmi from University Putra, Malaysia. So her study is a retrospective review of management of diabetic retinopathy in pregnant diabetics at Pusat Perubatan Universiti Kebangsaan Malaysia, PPUKM. So I would like to invite Dr. Nur Aniah Azmi to present her slides.
Okay, Assalamualaikum and a very good morning. I believe that everyone can see my slides. Yes. Hello, can you hear me as well?
Yes.
Oh, okay, and you can see my slides as well, yes?
Yes.
Okay, all right. Sorry very much for the delay. Okay, so this study was that we wanted to look at the management of diabetic retinopathy of diabetics, pregnant diabetics in the UK and NC. As we know that diabetes is always on the rise, and we also know that diabetic retinopathy may progress during pregnancy. And surprisingly, that diabetes is actually increasing around the world, and they develop at much earlier age. So the whole aim of this study was that we wanted to look at the rate of progression of diabetic retinopathy among the pregnant diabetics. For those who would like to know what we mean by progression, is that for diabetic retinopathy, we have multiple stages. We have mild diabetic retinopathy, moderate, severe, and then we have the more different category, which is the proliferative diabetic retinopathy. So we wanted to look at these patients when they progress from becoming at an earlier stage to become to the worst stage during pregnancy. So we looked at 168 pregnancies, and we traced the files from the endocrine antenatal clinic within 3 years of 2016 until 2019. However, we could only analyze 42 cases because only 42 patients out of the 168 had at least 2 ophthalmology follow-up. Then we can compare on their progression. What we have found was that the mean age was 34 years old, and surprisingly, majority were type 2 diabetes, which 95% of them were type 2 diabetes, and the rate of follow-up was actually very low. The 30% really completed their follow-up, and the progressors that we found among these were 7 out of 42. As mentioned, that the rate of progression was 17%, and all of them were type 2 diabetes and not type 1s, which were proliferative diabetic retinopathy and diabetic macular edema. As shown on this OCT, or the optical coherence tomography, which is a machine that we use to scan that we can see the layers of the retina, we can see that there is loss of the foveal contour, which indicates diabetic macular edema, as it is mentioned. So we found that the progression of diabetic retinopathy was seen in cases who had long-standing diabetes, and they also had poor sugar control. And majority of cases were type 2 diabetes and not the type 1. And this we could also see that there were poor ophthalmology follow-up, which indicates that it's difficult for the pregnant woman to actually receive an eye examination due to logistic reasons. And we did not find any correlation between the defaulters, no correlation between the parity, between the age and also the duration of diabetes that they actually had. So what we would like to suggest is that maybe we could put a non-myodratic fundus camera at the antenatal clinic, which would be more convenient for the pregnant diabetics, because I have read some reviews that in the UK, where they have a structured antenatal follow-up that is structured with the eye follow-up, that they have better control of diabetes, because we know that in diabetics, when they are pregnant, they are likely to progress. So this might actually help their proper follow-up as they go throughout their pregnancy. So in conclusion, what we found was that the follow-up rate for diabetic during pregnancy was only 30% for the ophthalmology, and progression occurred in 17%, and 2 out of 7 who progressed had sight-threatening retinopathy, and no risk factors were identified for diabetic retinopathy progression. Okay.
Okay, Dr. Noor Ania, yeah?
Yes.
Okay, very short study. It's a retrospective study, and I get a bit confused with your results. You mentioned that you mentioned that there were 42 patients. Betul?
Yeah. So 158.
Your
168
statistical analysis
was based on
how many
that
patients
42.
how many patients that did you put into statistical analysis? How many samples?
42.
42. And only two had progression of, two had two follow-ups. Only two patients had two follow-ups.
40, like this. So the bigger number of pregnant diabetic was 168, and among the 168, only 42 had at least two eye follow-up.
Okay, so 42 had two eyes follow-up, so they are the ones studied.
Yes, and among that 42, 7 of them progressed from one stage to the other.
Okay, so what are the parameters that you look out for to assess progression? You mentioned the two.
We look at
what are the parameters that you measure?
We look at the stage of diabetic retinopathy at their first follow-up of eye follow-up. So, for example, they have a mild NPR.
Okay, you look at the stage. What else?
At that stage, just the stage. And then the subsequent one, on the second follow-up of the eye, we see is it still at that stage or it progressed to a more advanced stage.
Okay, so the different stages that you measure.
Yes. And among that, we found that 7 of them progressed.
So how can you conclude from the 7 patients? Do you think that you can actually conclude from these 7 patients that there is a progression during pregnancy from your study? Is it a good number? Is it enough number to make such conclusion?
From these patients, we are in the literature, they progressed to MPP, categorized as progressed. Yes, we did see from the notes, unfortunately there was no fundus picture. So from the notes, you could see that they actually progressed from a less severe stage to a more severe stage. And that's how we concluded that they progressed.
And then your other conclusion about poor ophthalmology follow-up, can you tell us how do you actually arise to that? How do you, what are the factors that make you decide for such an important conclusion?
Because of from the 168, they were referred to the eye clinic. But then we traced back, they just went for the first follow-up and they were supposed to have actually an eye follow-up at least every trimester. But then they just come at the first trimester, and then the second and third trimester they don't present anymore to the clinic. So we could see that it may be challenging for them. The clinic is at a different level, or that's how we concluded with that. So that's why I thought that having a fundus camera just next to the clinic and we train the paramedics that would actually help.
Is your sample size the number of patients that you get is 42? If you compare to your initial sample size calculation, how does that differ?
It's 42 out of 168.
No, your initial sample size calculation before you conducted the study.
This is a retrospective study, so we just trace all the files that we had.
Okay.
Assalamualaikum, Ania. I think I understand where Prof. Nani comes from, because your presentation is actually too brief. Your results doesn't support your discussion. None of the things that you discussed has got data from your results. Okay, because in your results you just say that it's such a number of those who progress from such a follow-up and all that, but tiba-tiba in your discussion you say these patients progress because they have poor control of diabetes and prolonged duration of diabetes, which you do not have those data in your result. You cannot, come to a conclusion when you don't have data to say that their diabetic control is poor and they have prolonged diabetes, when you do not show any of us how long they had diabetes and what was the HbA1c level and what was all that. Number one. Number two, your objective actually does not reflect your title. Your title is to review the management of diabetic retinopathy. But your objective says you just want to see the rate of progression. So rate of progression and management is different. I mean, you can have good management but they progress anyway, or they can you have a poor management but they do not progress, So yours is, that's very important, especially when you want to publish this paper later, Number three, like what Prof. Nani said, your conclusion is of nowhere. I mean, you say that these patients do not come for follow-up because they have difficulty in coming, but they don't come to the ophthalmology clinic. Why is that? It couldn't be that they have difficulty coming to the hospital, but probably because they do not have enough awareness that their eye problem is as important as their antenatal follow-up. So making conclusions is it has to be precise and it has to be supported by data, and you cannot just make conclusions based on what you feel, but it has to be evidence-based. Thank you.
All right.
Okay, so thank you, Dr. Nur Ania. So the time is finished. Okay. So we move to the next presenter, Dr. Arlizan Baizura binti Arifin from Pathology Department. So her topic is value of high sensitivity cardiac troponin eye levels in patients with suspected acute coronary syndrome. So without further ado, I would like to invite Dr. Arlizan to present her slides.
Okay, thank you so much, Prof. Can everyone hear me? And can everyone see my slide?
Yes, yes.
Okay. Assalamualaikum and good morning to the respectable judges and my fellow colleagues. My name is Dr. Arlizan Arifin from Chemical Pathology from Pathology Department. Today I am presenting to you my research with the title of Prognostic Value of High Sensitivity Cardiac Troponin eye Levels in Patients with Suspected Acute Myocardial Infarction. Without further ado, I shall begin my presentation. Cardiac troponin is a regulatory subunit of troponin complex associated with cardiac muscle cells. It is released into the circulation within hours following acute MI or ischemic injury. So according to the 2018 fourth universal definition of myocardial infarction, cardiac troponins are the preferred cardiobiomarkers for the evaluation of myocardial injury, and high sensitivity cardiac troponin assays are recommended for routine clinical use. Its use as prognostication in acute myocardial infarction is well established. However, there is a lack of data on its prognostic value in patients who presented with a suspicion of acute coronary syndrome but does not fulfill the criteria of acute myocardial infarction, i.e. the non-acute myocardial infarction patients. Thus, in our study, we aim to investigate the association between HS trop eye levels and subsequent adverse cardiac events in non-acute myocardial infarction patients. This is a retrospective study of patients who presented to the emergency department of HCTM between 2016 to May 2018 with suspected acute coronary syndrome and had HS trop eye level measured during the index presentation. Those who were diagnosed with acute myocardial infarction were excluded from this study, and other exclusion criteria include those with the age of below 18 years old, those with underlying heart failure and stage renal failure, presented with cardiac arrest, died during index presentation, those who were hospitalized with acute myocardial infarction in the previous 3 months, pregnant women, trauma patients, like those who are involved in the motor vehicle accident, or patients whose follow-up were not available. Patients were then divided into 3 groups. The first group, Group A, were those with HS trop eye level of less than 10, which is our Can everyone still hear me? Yeah. I will resume my presentation. like that. So the HS TROP-I level in group 3 are continuous variables and not the categorical variables. As in the data that I computed in the SPSS are the values of HS TROP-I level itself.
So when you do cost regression analysis, your outcome is what? Is the event, the cardiac event, or
hazard ratio? Basically, the risk of the patient to
the hazard ratio is the result that you get. But when you calculate it, you have to have an exposure and an outcome, right?
Yes.
So your outcome is what again?
Subsequent adverse cardiac event.
Okay.
At 12 months follow-up.
So if you compare your hazard ratio of TROP-I with other literatures, or with TROP-T that we're using at the moment, how does it compare? Is it too sensitive? Is it?
Troponin I is better and more specific for for heart cardiac compared to TROP-T. TROP-T has more other.
Not necessarily for coronary artery diseases. Not necessarily for ischemic events. It could be heart failure and all that.
Yes, but TROP-T is also the same, but TROP-T can also be raised in, it's more profound in, the elevation can be profound in other diseases like any renal disease. So in terms of comparison, TROP-T and TROP-I is more cardiac specific.
Okay. Thank you.
Thank you. Thank you.
Okay, thank you, Dr. Alizan. The time is finished. All right. Okay. So we shall proceed with the next presenter, which is Dr. Nur Shahirah binti Saleh from pathology department. So her research topic is, her presentation is on serum ferritin and malondialdehyde MDA, okay, levels in type 2 diabetes mellitus patients, pre-diabetes and non-diabetes. So without further ado, I would like to invite Dr. Nur Shahirah to present the research.
Okay, Assalamualaikum warahmatullahi and very good morning. Thank you, Prof. Asrul, and also to the good morning to the judges. Today I will present my research topic entitled serum ferritin and malondialdehyde in non-diabetes, pre-diabetes, and also in type 2 diabetes mellitus. Okay, lipid peroxidation has been documented to play a role in the pathogenesis of type 2 diabetes mellitus by reacting with iron and causing cell damage. Malondialdehyde, which is also known as MDA, is a product of lipid peroxidation. It was reported to be increased in type 2 diabetes mellitus. However, recent study have found that ferritin and iron ligand was elevated in type 2DM. However, this study did not measure both ferritin and MDA in type 2DM, and only one study included the pre-diabetes. So the aim of my study is to determine the relationship between serum ferritin, MDA, and HbA1c in type 2 diabetes mellitus patient, pre-diabetes, and also in non-diabetes subject. Okay, sorry. So this was a prospective cross-sectional study which was conducted from March 2019 until February 2020. The subjects were comprised of type 2 diabetes mellitus patient, pre-diabetes, and also a non-diabetic subject. The selection of the subject were based on the HbA1c level in accordance to the Malaysian CPG for diabetes mellitus 2015. For type 2 diabetes mellitus, the patient has the HbA1c of equal or more than 6.3. For pre-diabetes, the HbA1c is between 5.6 to 6.2. And also for non-diabetes, the HbA1c is less than 5.6. All subjects were recruited from the endocrine clinic, Hospital Chancellor Tuan Kemukris, and also from the hospital staff. And patient with conditions that may affect the HbA1c, ferritin, and also MDA result were excluded. The exclusion criteria include the hemoglobinopathies, patient with anemia with repeated blood transfusion, patient with chronic infection, chronic liver disease or kidney disease, and patient on antioxidant supplement, and all subjects gave written informed consent. So for the measurement of the test for HbA1c is by using the ion exchange HPLC. Ferritin was measured by immunoassay, and the plasma MDA was measured by ultra performance liquid chromatography. The height and weight of the patient were taken to calculate the BMI. So here are the results of my study. So out of 100 subjects, 35 was the non-diabetes, 31 pre-diabetes, and also 34 was type 2 diabetes mellitus patient. BMI was significantly different across all the three groups, being the highest in the pre-diabetic group. Since the subjects were classified based on the HbA1c level, it was expected that the HbA1c in the type 2 diabetes is higher, and the HbA1c in the non-diabetes group is lower. If we look at the first figure here, so the type 2 DM recorded the highest median for ferritin level, and the difference in the ferritin level was only significant between the non-diabetic and diabetic group with the p-value of 0.013, while the difference between the non-diabetes and pre-diabetes and between pre-diabetes and type 2 diabetes mellitus were not significant, with the p-value of 0.111 and 0.331 respectively. Okay, then for plasma, the next figure is showing the plasma MDA levels in non-diabetic, pre-diabetic, and type 2 diabetes mellitus patient. So the median plasma MDA was the highest in the type 2 diabetes mellitus group. For plasma MDA, the difference was significant between all the groups with the p-value of less than 0.001. However, we found that the MDA was lowest in the pre-diabetic group. Next, for correlation, I did a correlation. So the correlation study shows that there was significant correlation between the HbA1c and ferritin with the R value of 0.229, and also there's a significant correlation between HbA1c and MDA with the R value of R 0.378. Despite this good positive correlation with these two positive correlation, we found there was no correlation between MDA and ferritin. I did not include it in the slide. So for discussion, in this study, ferritin was significantly higher in type 2 diabetes mellitus compared to non-diabetic, but not compared to pre-diabetic. So a previous study did report the higher ferritin in pre-diabetic as compared to healthy subject. Ferritin, also known as also acting as an acute phase reactant, may be elevated in individuals with low-grade inflammation. As in my case, it can be associated with obesity and type 2 diabetes mellitus. So in our study, pre-diabetic has the highest BMI, which may contribute to the non-significant difference between the pre-diabetic and the type 2 diabetic mellitus group. And we found that the MDA level tends to be highest in the type 2 diabetes mellitus group and lowest in the pre-diabetic group. Thus, there was no continuous increment in the MDA. But according to our correlation study, HbA1c correlated more with MDA than ferritin. However, there was no correlation between ferritin and MDA, suggesting that both of them were associated with type 2 diabetes mellitus, but independently. So in conclusion, although this study show high ferritin level in type 2 diabetes mellitus, our data did not support ferritin as a mediator of the oxidative stress in the pathogenesis of the type 2 diabetes mellitus. That's all.
Okay, thank you. So I open for question and answers.
Okay, thank you, Dr. Shahira. Okay, my questions would be, can you tell us what will be the significance of your study in clinical setting? That is number one. And number two is that there is a linear by right based on the relationship between ferritin and MDA. There should be a linear correlation by right, because it's a byproduct. MDA is a byproduct of ferritin. So why do you think that in your study that there is no correlation between these two substances?
Okay, thank you for the question. So for the the clinical relevance for my study, this study was done because a previous study has shown that elevated ferritin was associated with increased risk for patients with diabetes mellitus. So my study was proposed to clarify whether ferritin has the potential to be a test to predict an individual's tendency to develop diabetes via the oxidative stress, which is indicated by MDA. So if my result is promising, if the result is positive, promising, so in future maybe larger study can be done to determine the cutoff point if ferritin can be used. But in my study, it shows that ferritin cannot be used at the moment lah. So for the second question, if the pathogenesis for diabetes mellitus from MDA is like iron will produce iron in the body will involve in a reaction which cause the production of the reactive oxygen species. The reactive oxygen species will oxidize the lipid which leads to the production of MDA. So this MDA is responsible for the biomolecular damage. For example, in diabetes is to the pancreatic beta cell lah. And then the non-correlation can be due to many confounding factors that I must say. For ferritin, we know it's an acute phase reactant. In my study, I only exclude the inflammation based on history and also based on the available info. I didn't go into further like taking CRP. I think the better if we can adjust the patient selection with CRP level so that it will be more accurate. And also MDA itself, it has a lot of confounding factors. Like although I have exclude the patient on diet on antioxidant supplement, but there's still possibility of the effect can be due to lifestyle and then dietary habits like food diet with high antioxidant or something. That one I'm still looking into that data to support my findings at the moment.
Thank you.
Thank you, Dr. Nur Shahira, for a very good study conducted. I think the data is very well presented. I have a few questions. So you say this is a prospective cross-sectional study. When you say prospective, that means you recruit a subject and then you follow them up over a period of time. Is that the case?
No, actually I didn't follow the vision. I just said one off. Yeah. Cross-sectional. I think it's not prospective actually.
Is that so?
Sorry, I couldn't get you because the line is not close.
Okay. I just want to understand the sequence of events. So it starts with lipid peroxidation. From that, you get MDA, and subsequently you get ferritin, raised ferritin level. No?
Ferritin comes first because ferritin produce the reactive oxygen species that cause the lipid peroxidation.
Okay, so therefore, when you say in your discussion, right, you say we found MDA levels to be highest in type 2 and lowest in pre-diabetics. Thus, there was not a increment. But I thought, you know, if you have lower in pre-diabetic and higher in diabetics, then you do get continuous increment in MDA, no?
But then my pre-diabetic is lowest compared to normal as well. Normal
Is
my
that by
is higher.
and that's statistically significant?
Yes.
Because your correlation shows nicely that it is well correlated between what was it again? MBA and HbA1c level, right? So, I mean, if you go, you know, if you compare ferritin actually does poorly compared to MDA in relation with your HbA1c. And I would thought that it's better for you to use MDA rather than ferritin to diagnose your pre-diabetics against diabetics or against normal. So how do you explain that?
Um,
Or how would you verify or validify this result of yours? Because I thought the whole idea of doing this is so that you can get a better diagnostic predictor to differentiate between pre-diabetics and normal and diabetics, right?
yes. So
But here, you couldn't get a very definite.
the thing that I can explain is just like it's just the confounding factors that may affect my MBA result. Because there's a lot of confounding factors from the pre-sampling process during the analytical process. Pre-sampling process can be due to patient factors itself lah. For example, from the diet history and then the lifestyle, and also ferret. I think that's maybe the pathophysiology, although it says that iron will cause the increment in MDA and also causing diabetes, maybe there's some other factors that can contribute to the
Dr. Nushairah, I have to stop you here because your time is up. Okay. So thank you for your presentation. I think we take break until 10:30. We will start again at 10:30. So the next session we will start at 10:30 with with Nur Aidatul Akmal Abdullah. Okay. So we take break until 10:30.
Okay, we are going to continue the session. So the next presenter will be Nur Aidatul Akmal Abdullah from UMPI. So she's going to present on the topic of anemia and associated risk factors among the Malaysian cohort participants. So I would like to invite Nur Aidatul Akmal to present on her slides.
Thank you, Prof. Dr. Asrul, for your kind introduction. Assalamualaikum and a very good morning. I wish to honorable judges and respected audience. Today, I'm going to present on anemia and associated risk factor among the Malaysian cohort participant. Anemia is a condition in which the red blood cell count or hemoglobin is less than normal. The World Health Organization has reported that approximately 1.62 billion suffer from anemia, which correspond to almost 1/4 of the global population. In Malaysia alone, the prevalence of anemia was 24.6% as reported by NHMS 2015, while the prevalence in male was 14.3% and 35.5% in females. Anemia is not merely a medical condition, but may also be a reflection of certain social issues because of the close association with insufficient earning, poor nutritional status, and aging. The objectives of this study was to determine the prevalence of anemia among the Malaysian cohort participants and also to determine the risk factor that associated with anemia among the Malaysian cohort participants. This is a cross-sectional study that derived from the Malaysian cohort project, which comprises 102,388 participants. None of the participants were pregnant during the recruitment process. And this study was conducted between April 2006 until September 2012. Blood samples were collected in 3 male vacutainer EDTA tubes, and then the full blood count was performed on the LH750 Beckham culture with culture principle method. And then, based on the WHO guideline 2008, anemia is defined when hemoglobin is less than 30 grams per deciliter for male and less than 12 grams per deciliter for females. The prevalence of anemia in this cohort population was slightly lower than NHMS, with overall prevalence of 13.8%, while 4.9% in male and 20.1% in females. Majority of the participants having the microcystic hypochromic type of anemia. The prevalence among female was highest among those who were aged younger than 49 years old and then decreased as the age increased. In contrast, the prevalence of anemia increased in males by increasing age. Gender, ethnicity, age, marital status, platelet disorder, and kidney disease were significantly risk factors that are associated with anemia and contributed to 14.9% of risk of developing anemia in the Malaysian cohort participant. The prevalence of anemia among the Malaysian cohort population is 13.8%, which is relatively lower compared to some other cohort studies. The prevalence was lower might be due to the method that we use in this cohort study, which was venous hemoglobin measurement compared to capillary blood in previous studies. The majority have microcystic and hypochromic anemia, which is likely due to iron deficiency and also hemoglobinopathies such as thalassemia, Thalassemia is common in Asian, including Malaysian population, in certain ethnicities such as Malay, Chinese, Aborigines in Peninsula and also Kadazan Dusun in Sabah. Many are unaware of their anemic status. Hence, there is a role in doing a full blood count during the annual health screening to identify those who were affected. With this, I would like to thank our principal investigator, Professor Datuk Dr. Irama Jamal, staff and also the voluntary participant of the Malaysian Cohort Studies. Thank you to UKM, UMBI and Ministry of Education who sponsored this, who funded the Malaysian Cohort Study. With this, I thank you.
Okay, thank you, Aida. So I would like to open for question and answer sessions. So you have another 7 minutes for this. Thank you.
Thank you, Dr. Aida. I just have a few questions to ask. So this is from a Malaysian cohort study, and I would gather that the participants from this study would come from all over Malaysia.
Yes,
Is that right?
that is correct. Yep.
Okay. Do you have any particular classification of the participants in terms of like what you say? Some are orang asli, some from the rural areas, or some from the urban areas. And do you find a difference in the distribution of anemia among these different groups of participants?
Yes, according to the our data, the prevalence of anemia is highest in Indian population compared to Malay and Chinese and other population. I think it is due to the dietary pattern of Indian, which is most of them are vegetarian. So that's why it's contribute to the higher prevalence of anemia among Indian participants in the Malaysian cohort study.
Do you have data on their income? I mean, do poorer people get more anemic compared to well income patient?
We do unfortunately we do not have the income status at the beginning because it's but we introduced the income questionnaire during the follow-up phase, but it's quite hard to get the actual answer from the participant. Might be due to the because maybe they are afraid of telling the truth. Maybe they afraid of income tax or stigmatism. So for the socioeconomic status, we are using the education level to replace to reflect the economic status of the participant.
So you can get more data from what the preliminary HB level. You can get more data from that.
Because this is based on the baseline data, and now we are in the phase of follow-up data. We already introduced the the income questionnaire during the follow-up status, but it's quite hard to get the true answer from them.
Yeah, I do understand that, but looking at your slides on the risk factors that you have identified, I think it's quite scarce in the sense that there are a lot of other things that you can look into, especially dietary intake, and because you just have like some diseases, divorce or widowed and all that. But to be meaningful, to be applicable to the population, some things like diet and social economic status and things like that would help even more in terms of I don't know, budgeting to provide meals for children or things like that, So when you do some, cohort studies like this, you want to give something back. You use the data to plan your economic distribution and things like that. So these are the things that people look into. Thank you.
We do have the data, Prof, but during the analysis, this is the only the data that's significant that in the final models. That's why I just presented the data that are significant. But in the initial analysis, we include all the relevant risk factor which that you are mentioned earlier, which is diet and other risk factor. But it is not the data is not significant, so we don't include it in the final model. So the one that I presented here is only the one that are significant until in the last models.
Okay, Aida,
Yeah.
I have two questions here. The first one is that why do you have any reason or reasons to put forth on why in female less than 49 years old they have a higher numbers of people being anemic? That is number one. Number two is that in your conclusion, you have put forth that one of the reasons for microcytic anemia in your study would have been thalassemia. Is that right? And
Yes,
if
that's
yes,
correct.
why? If yes, why is that so? Why do you put such reason when there is none to suggest based on your methods or your analysis?
Thank you, Ms. Nani. And for the first question, the reason why the prevalence of anemia were higher in female that age 49 and below, because at this age, they are the prevalence is higher because of the menstruation, because this is the age that still in a productive age. But as you can see in the graph here, the prevalence is reduced when the age is 50 to 59. This is the age where most of the Malaysian women hit the menopausal status, and that's why we can see the pattern here. But it's different with the pattern with male. And for the second question, the reason why I said the majority have microcystic and hyperchromic due to the thalassemia is because even though we do ask the participant about the thalassemia, but the data is very small to present in this study, and because we know that we in Malaysia we don't do the screening for all our
Berhenti eh?
Okay, I think that's all. Thank you, Aida. Okay, for your presentation. So, we shall proceed with the next presenter, which is which is Muhammad Amirul Fitri from parasitology. So again, the topic is about anemia actually. Okay. So the prevalence of anemia and its associated risk factors among orang asli community in malaria risk areas of Musang, Kelantan. So without further ado, I would like to invite Muhammad Amirul to present on his research.
So, can you all hear my voice? Okay. Assalamualaikum and very good morning to all the lecturers, staff and students. My name is Muhammad Amirul Fitri from Department, a master student from Department of Parasitology. Today, I would like to present my research entitled The Prevalence of Malaria, the Prevalence of Anemia and its Risk Factor, Associate Risk Factor among orang asli community in malaria risk area of Musang, Kelantan. As introduction, malaria is a major cause of anemia in tropical area, and it still remains an enormous problem in public health around the world. Malaria infection causes hemolysis of erythrocyte and dierythropoiesis, which compromise rapid recovery from anemia. People that hard to reach and marginalized population that living in malaria risk area, such as orang asli, are more vulnerable to anemia with greatest impact, particularly in young children and also infants. Objective of my study is to assess the prevalent and associated risk factor of anemia among orang asli community in malaria risk area in Gua Musang, Kelantan. Moving to methodology, cross-sectional survey was conducted in 5 villages of orang asli in post-Kuala Betis between June to July 2019. Individuals were provided blood sampling by fingerprint in order to assess malaria infection by microscopy, and then hemoglobin level was measured by using HemoQ machine. As a result, this table shows characteristic and anemia status among the 5 villages of post-Kuala Betis in Gua Musang district. In overall, 640 participants were involved in this study, and 58% were from female and the remaining were male with 42%. The mean of the age that involved in the study is 22.6 years. And then we stratified into 5 age group, and the majority of respondents were from age group 6 to 15 years old with almost 30%, and the lowest is from age group 50 years and above with 63 participants. In terms of hemoglobin level, the mean, there is no significantly different between the 5 villages, and the mean is 12.1 gram per deciliter. With regard of anemia, there is significantly different between the 5 villages, which is the Kampong Podek has the highest anemia, followed by Lambok and the lowest in Betak. And then we stratified into 3 types of anemia, and moderate anemia have the highest anemia with almost 49%, followed by mild anemia, and the lowest in severe anemia with 7 participants or 4.2%. Next, the result here is men's anemia specific prevalent and its risk factor among the respondents in post-Kuala Betis. The first figure show anemia specific prevalent in terms of gender, age group, and village. In terms of gender, we can see that we found that female have the higher anemia rate compared with 58.8% compared to male and with 41.2%. In terms of age group, we can see that participants from age group from 5 years and below have the higher anemia rate with 43%, and the lowest from age group 50 and above with 4.2%. In terms of villages, we found that Kampong Podek has the highest anemia rate with 35.2%, followed by Lambok and Angkek. By using multivariate logistic regression, we found that age group and village are specifically age group and people living in specific village has a high risk anemia in the population. We also found that the age group less than 5 years old have about 19 times significantly higher odds to have anemia compared to participants from 5 years old and above. Furthermore, people that living in Lambok has 6.5 times significantly higher odds to have anemia compared to those living in Betak. As conclusion, this study highlight the high prevalence of anemia among the orang asli community in Gua Musang district. Specifically, the result revealed that the younger children and adolescents were positively associated to childhood anemia. Therefore, it is crucial that a comprehensive primary healthcare program that include community health and education are taken into consideration to improve the health status of these children. As an acknowledgement, we would like to thank the local community and district health personnel for study participant, and this study was supported by GGPN grant and ASTIF grant. Thank you.
Okay, I open for question and answer session. Thank you.
Thank you, Encik Amirul Fitri. Can I just clarify, when you, in your methodology, so you took full blood count and something else, BFM something?
Sorry, Prof. Basically, we only took
BFMP. What is that for?
blood blood parasite microscopy is parasite count.
Okay, so you took both full blood count and parasite count, this BFMP thingy.
Sorry, Prof. We only took finger pricks. We don't do the blood
Okay, all
count.
right. Okay, so you
FMP
took
is for parasite microscopy observation, parasite count.
okay. So do you have that result in your result? The BFMP data in your result? Do you have that?
Sorry, I didn't show in the slide in the part session because all the respondent for these 5 villages were negative in microscopy.
And you do BFMP to look for malaria or what?
Yes, we'll do the BFMP to look for malaria. And
So, okay. So the villages that you sample are not malaria malaria risk areas?
Basically it has the previous case the last 2 years. So our country in this year 2020 are moving to elimination. So we try to look at the elimination target achieved and we look also with the anemia.
Understand. So perhaps if you want to give a better
Sorry, doctor, the line is not clear. Sorry. Sorry, hello. Sorry, Prof.
yeah, Amirul, yeah, you're back. So what would be a better title instead of saying prevalence of? I would assume that the community that you sampled were high malaria level. Your BFMP will be positive for 40% of the participants, but here you have 0% and
maybe I can discuss the only prevalent of anemia and its associated risk factor among orang asli community. But I discuss the in malaria risk area instead. I will.
Okay, thank you.
Thank you, Prof.
Amirul, Miss Nani, yes. Okay, so you punya results, location is one of the main factors that predict the risk of malaria in these places. So what are the differences between, or difference yang you can gauge among all these places that you sampled? And second question would be, you have quite a number of school-going children sampled in your the groups of patients, kan, your samples. Why is that so?
Sorry, Prof. Can you repeat the first question because the line is not clear. I didn't get the first question.
The first question is that what are the differences between or among the places that you sampled the patients from? You ada berapa places tadi?
Five villages. Five. Yes. So the difference between the maybe the distance from the river each, and the difference between to the healthcare or clinics they can go seek for help if they seek for treatment if they got sick between the 5 villages and that's for the first question. The second question
in relation to
sorry, in relation to what is that?
Okay, the second question is that apa tadi punya second question? You sample quite a number of school-going children in your
study.
Yes.
Basically, it's because the school going more contribute. We are doing this survey during the day. then mostly their parent and the adult age to they are off to work and we cannot and we cannot it's our limitation that do not do the survey during the night because we facilities to go in that villages and that's why most participants in the study were from age 6 to 15 years old, more from schools students.
Okay, thank you.
Okay, thank you, Muhammad Amirul. I think the time is up. Okay. So we are going to proceed with the next presenter, which is Dr. Khatijah B. Muhammad Ali from JPPP, Jabatan Perubatan. So the topic is location and patterns of persistent pain following cardiac surgery. So without further ado, I would like to invite Dr. Khatijah B to present on her findings.
Okay. Assalamualaikum. Good morning, everyone. Can you hear me?
Yes.
Yes. Yeah. Can I start now? Yeah.
Can start now.
Okay. Assalamualaikum and good morning, everyone. It is with pleasure that I present some of the work that for my PhD. Sorry. So the title of my study is Location and Pattern of Persistent Pain Following Cardiac Surgery. Median sternotomy remain the preferred institution for cardiac surgery with 1 million procedures worldwide. A significant numbers of patients develop post-sternotomy persistent pain. The pain continued to be reported by patients over 33 to 66% lasting more than 3 months. Out of this percentage, another 25 to 33% reported chronic pain that interfere with everyday tasks for more than 2 years. The pain is prevalent and contribute to impaired physical function and delayed recovery. However, details regarding differential clinical features of musculoskeletal chest pain after surgery are relatively unknown. So, therefore, the primary objective of the study was to investigate the specific clinical features of pain following cardiac surgery, and secondly, to evaluate the information derived from different pain measurement tools used to quantify and describe musculoskeletal pain. This study was conducted and reported in accordance with strengthening the reporting of observational study in epidemiology with stroke guidelines. So we designed a priority of pain substudy within a prospective randomized control trial conducted at Royal Melbourne Hospital and Melbourne Private Hospital. 72 participants post-operative cardiac surgery while median sternotomy completed all pain measures prior to hospital discharge at 4 weeks and 3 months post-operatively. Descriptive statistics were used to summarize demographic and operative data. A general linear model was selected to analyze the repeated measure considering the change in the outcomes over time. Relationship were assessed using Pearson and Spearman correlation coefficient as appropriate. All p-value were 2T and p less 0.05 was considered statistically significant. The strength of the correlation was interpreted based on the criteria highlighted in the slide. The primary outcome measure was patient-identified cardiac pain using numeric and visual prompt, inclusive of firstly, a numerical rating of pain scale. Let's see it. Secondly is semantic representation tool and location and pattern of presentation. And thirdly, pictorial identifier that visually description of pain. Other outcome measures include McGee Pain Questionnaire, which is short form version 2, and medical outcome study 36 item version 2, bodily pain domain. I'm now going to present the result. The sample size was typical, as you can see, the sample size was typical of cardiac surgery population with the mean age being 63 years and the gender distributing bias in male. At baseline, you will find that on baseline on numerical rating of pain scale, participants experience a high to moderate pain at 63% and 31% respectively, which reduced at 4 weeks post-operatively, where mild pain at 41% and moderate pain at 7%. And at 3 months, there are 20 participants reported mild pain and 3% moderate pain. The most frequently selected Median Pain Questionnaire term correlate with the description of pain of acute musculoskeletal injury and trauma, such as tiring, exhausting, which is at 88%, tenderness at 26%, and aching at 26% at baseline. At 4 weeks and 3 months, the neuropathic pain symptoms such as numbness, aching, tenderness, and hot burning were chosen more frequently. In terms of schematic presentation of the tool on location and pattern of presentation, the frequent location, as you can see, was the anterior chest wall and gradually reduced up at 3 months post period, where from 88%, 85% to up to 55%. Yeah, so there is small portion of participant reported pain at the shoulder arm at 35% over time, which you can see highlighted by the green color. In terms of PICP, on pictorial identifier that visualize represent description of pain, you can see that most participants choose pressure or weight to aching or heaviness in the chest region, and the pain topography was persistent at 4 weeks and 3 months post-operatively. Mild to moderate pain is frequent after sternotomy, which improves over time and is mostly located over the incision and mammary internal artery harbor sites. The high incidence of acute post-op is attributed to the mechanical and physiological demands of surgery. Persistent muscular strain at 3 months remain a severe problem in the community within the surgical population. At 3 months, we found a quarter of participants reported symptoms over the internal mammary artery and radial artery harbors, consistent with the documented internal mammary artery syndrome, and which is recognized by International Association for the Society of Pain. Each pain tool provided different information on clinical features, on pain location, with significant change over time. So this study provides us with a better understanding on the specific clinical feature of post-sternotomy pain to guide health professionals in the delivery of preoperative and post-operative pain educations. Yeah? Further study are warranted to investigate whether a battery of pain measurement can better inform clinical management and patient education, facilitate safe management, and better patient outcomes. Thank you for your kind attention.
Okay, so I would like to open for question and answer session.
Thank you, Dr. Khatijah. Just a few questions. So in your data collection, so you take note of the site of the CABG graph taken from, such as the radial artery, the mammary artery, and then and so forth. And you nicely identify or locate the areas of pain.
Yes, yes.
And you conclude that some of this pain could be attributed by the location of the graph taken.
Yes, yes.
Did you analyze or did you correlate between the location of the pain and the site of the graph taken? Did you have that in your data?
Yeah, we did, because we look at the correlation. Because what we find is that it's not significant because the sample size is too small. This is because this is like the limitation of our studies. Yeah. And I know pain studies has to have bigger sample size. We actually did the multiple logistic regression, look at all, and because it's not significant, that's why we didn't present this data.
There was some, and can you go back to the analysis section, the methodology? So you did something on generalized linear model for repeated measures. So what data was that on?
Yeah, I did because it's 2 weeks. So, but I have the data now. So if you can look, this is
for which one?
For all the 3 pain measures.
So you do this because you want to see which pain measures is more accurate, or
accurate? Yes.
Okay, so which one is accurate again?
if you look at it, it's actually numerator rating scale, which is a better instead of McGill's and SF-40. Yeah, we found that actually numerator actually has the more accurate. We did the analysis and found that's the best for to measure pain in our population.
And that is the least sophisticated.
Yes.
NRS.
Yeah.
More straightforward and things like that. Okay.
Dr. Khadijah,
Yeah.
Okay, I just have one question here. You did such an extensive, quite an extensive study on pain, kan? So what would be the bias in this, in your study?
Of course, the bias is, I think, is small sample size, which cause I think the bias is more of sample size because we don't have dropout in our study, and we have low attrition bias because we only have 4 missing data, and we actually calculate it within our statistic, but it's not significant even though we have only four missing data, but our population, but we don't have those, so it's just, but the sample size, the small sample size actually holding our finding.
What about the pain relief that these patients received?
Yeah, I did collect all the data. It's actually across the 72 participants. This is actually a randomized control trial. That's why it's actually a prior subset of our randomized control trial. And the standard care for pain management is same. And there is no, we already have analysis. There is no significance between on the pain management for both of this group for 72 patients here.
Okay, so the appropriate patients actually received breakthrough pain relief and
yes, and then it's more actually they have a combination of low and high, longer duration of pain relief. So they both these two have, yeah.
Okay, thank you.
Sorry, can I clarify just now? So you said this is a randomized control trial. Is that right?
Yes, that's why I said this is actually this is actually a part of a subset of randomized control trial. Yeah.
But you know, you're presenting part of it, and this in itself, you know, when you say randomized control trial, you have to randomize the patient whether receiving this treatment or that treatment or things like that.
That's why
I don't see that happening in this study that you just presented.
No,
description of the study design.
Yes, I said this is reported based on observational study because we design a priori a pain sub-study within a randomized control trial. So this is the priori of the sub-study from the randomized control trial.
But this would be an observational study, would you?
Yes. That's why this study was conducted and reported in accordance with the stroke guidelines on observational study. Yeah.
Okay, thank you.
Okay, thank you, Dr. Khatijah. So, the time finished. Okay, we are going to proceed with the next presenter. So the next presenter is Munawara binti Pardi from IKU. So she's going to present on the topic of risk factors associated with general and abdominal obesity among elderly in Malaysia. Findings from National Health and Mobility Survey 2019. So I would like to invite Munawara to present on her topic.
Okay, Bismillahirrahmanirrahim. Thank you, Prof. Assalamualaikum and a very good morning. Ladies and gentlemen, I am Munawara, dietitian from Institute for Public Health, National Institute of Health, Malaysia. And I'm here to make a short presentation on factors associated with general obesity and abdominal obesity among elderly in Malaysia. A finding from National Health and Mobility Survey (NHMS) in 2019 shown that 1 in 2 adults in Malaysia were overweight and obese. 1 in 2 adults in Malaysia were found to have abdominal obesity. And this was found to be the highest among the female, Indian ethnic, and at older age. In line with that, there was a rapid escalating of obesity prevalence in Malaysia from 13.4% in 2011 to 18.3% in 2019. Abdominal obesity is a stronger predictor of cardiovascular diseases. Other major diseases related to overweight and abdominal obesity were diabetes and high blood pressure. And another interesting piece of information from this current population-based study, 1 in 5 adults in Malaysia have diabetes, 1 in 3 adults have high blood pressure, and 1 in 2 adults have high cholesterol. And this have been highlighted and threatening Malaysians for the health risk status. Both general obesity and abdominal obesity were associated with the risk of death. And this becomes more interesting when we talk about healthy and peacefully aging. Now, let us look further at the aspect of general obesity and abdominal obesity among the elderly in Malaysia, and what are the risk factors that related into it. Let's move to the next session, the methodology. The data derived from National Health and Mobility Survey 2019, and it was being used in this sampling. This is a cross-sectional population-based study in two-stage stratified random sampling. About 4,351 respondents aged 50 years and above was stated in this study. And a face-to-face administered questionnaire was used to capture the socio-demographic and the lifestyle factors, while the anthropometric data was measured by weight, height, and waist circumference based on the WHO criteria and International Diabetes Federation criteria. And this data was analyzed using the SPSS version 23. So with regards to the data analysis, let's look at the prevalence findings of the respondents. General obesity among the elderly in Malaysia was 19.3%. Among them, the higher prevalence was found at the age of 50 to 59 years, 22.0%. Elderly who live in urban, 19.5%. Being a female elderly, 25.3%. Being an Indian ethnicity, 26.3%. Having 1 to 2 sugar sweetened beverages, 23.4%, and was not smoking, 21.2%. While the prevalence of the abdominal obesity among the elderly in Malaysia was 66.3%. Among them, the higher prevalence was found at the age of 50 to 59 years old, 66.5%, still living in urban locality, 67.4%, being a female, 78.7%, and being an Indian ethnic, 77%, and having 3 to 6 sweet drinks per week, 71% with not smoking, 69.3%. Well, the most interesting part was this variable was found similar with the risk factors for metabolic syndrome among middle-aged Malaysians as being done by Muhammad Wan Nazaimun et al. In 2011, which was seen as higher risk in urban areas, being female, being in Indian population, and significantly increased by age. Now, we move on to the multiple logistic regression analysis to find out what's the risk factors that might relate to general obesity and abdominal obesity among the elderly. With the p-value less than 0.05, factors as age, 50 to 59 years old, being a Chinese ethnic, and having 3 to 6 sugary drinks per week were significantly associated with both general obesity and abdominal obesity among the elderly. And here are the interesting part of this finding. A smoker was found to be a protective from both general obesity and abdominal obesity among the elderly. Well, smoking and obesity is still in a debate issues and was completely understood. Some studies show no significant others suggest smoking may associate with low BMI. So, and these are the key points of my findings today. Obesity and abdominal obesity were clearly seen among the elderly in Malaysia. Factors as older age, gender, ethnicity, and healthy lifestyle should be considered in promoting future intervention in this vulnerable population in Malaysia. And for those who are smoking, was likely to have the general obesity, to have general and abdominal obesity. So we should have more studies on, there should be more studies on relation between obesity and smoking for further clarification in this method. So with that, bring me to the end of my presentation. And thank you for your attention.
Thank you, Puan Munawara. There are a few things that you need to explain to us. Number one, your results are somewhat contradicting. So the first slide of your results says that Indians are more likely to have abdominal and general obesity, but when you go to the univariate logistic regression analysis, you find Chinese to be more prone to have this kind of things. So how do you explain that?
It could be because of the total sample. Because the Chinese total sample is only 17.8%, and the Indian is 6.7% from the total sample.
Okay, you adjust for that.
Huh?
How can you adjust for that?
I couldn't get your question.
So it all boils down to statistical analysis, right? So if you use the correct statistical analysis, your data would not be contradicting. See the first slide that you show us, you just give percentages, and you don't give p-values to compare within Indian and Chinese and Malays.
Yeah, yeah.
Okay. So if you can go back to your first result slide. Because there's a lot of things that does not tally. Okay, number one, the gender. Number two, your sugary intake. Okay, so it appears like the more sugary intake you take, the less likely you are to get obesity. And the one thing that you pointed out is that smoking has a protective effect against obesity. I mean, you know, you don't want to give that kind of impression to the general public, right? Okay, so this general obesity, abdominal obesity, so you say Indians are more likely, 77% of them develop abdominal obesity, but you don't give a p-value to compare that with the other ethnicities similar to females and, you know, all that things. Because of that, so when you go to the next slide and you found contradicting results. So now tiba-tiba Chinese becomes the ethnicity who develop abdominal and general obesity. So when you do not, you know, sometimes when you do statistical analysis, it can happen by chance, but you have not defended yourself by showing us a very concrete analysis, statistical analysis that you've done. You know, so there's a lot of fault in your statistical analysis, I would say.
Okay, I admit that. I'm very sorry, and I think I take it as my experience. Thank you, Prof.
Okay, Munawara. My question would be this survey by National Health and Mobility Survey ni, how were the participants sampled?
Participant sampling, it is a random sampling.
Random sampling macam mana?
We use two stage stratified, urban and rural area.
Okay, so how were the patients recruited macam tu? You jumpa orang ke?
Yeah.
Kat mana? Where?
At selected houses that being selected lah by Jabatan Perangkaan.
Oh, you go to houses?
Yeah.
I see. Okay. So based on your, I just want to, out of curiosity, your focus group, elderlies, and this problem of obesity is actually a general problem even in kids and even in general adults.
Yeah.
Why is it so specific to elderly more than 50 years old?
Because when you are aging, everything slowing down. So our aim now is to have a peaceful aging. So by hope, when you control your weight, then there is other disease age related will be slowing down.
But by this time, these patients have had all the triple diseases, the general diseases, diabetes, hypertension, hyperlipidemia kan, by this age group generally.
Okay. So perhaps it won't make it make it worse to them.
Yeah, but generally prevention is better than cure.
And that's very hard to have the prevention part.
Okay. Thank you.
Okay, thank you, Naura. So we are going to proceed to the final presenter for this session. So the will be Dr. Wan Muhammad Azifar, Wan Shuaib from Pathology Department. So he will present on the topic of third trimester serum uric acid levels in prediction of preeclampsia. So without further ado, I would like to invite Dr. Wan Muhammad Azifar to present on this topic.
Okay, Assalamualaikum and a very good evening, very good morning. So I'm Azfar actually from Pathology Department. So today I'll be presenting on the third trimester serum uric acid levels in prediction of preeclampsia. So before we proceed, what is preeclampsia? Basically, preeclampsia is new onset of hypertension and proteinuria, or new onset of hypertension with end organ dysfunction with or without proteinuria after 20 weeks of gestation in a previously normotensive woman. So preeclampsia is actually one of many adverse pregnancy outcomes that can occur in a pregnant lady, okay? But basically it can lead to roughly around 10% of all pregnancies in this world. Specifically in Malaysia, is roughly about 13.5% of occurrences of preeclampsia based on studies done in 2015. So with regards to preeclampsia, now we talk about the association of hyperuricemia. What has uric acid has got to do with preeclampsia? So basically, it has been postulated that high levels of uric acid, what they can do, they can induce endothelial dysfunction and cause a depletion of nitric oxide, which will then lead to abnormal placental implantation, contributing to the development of preeclampsia. It also affects the maturation of the spiral arteries as well. It also induces oxidative stress, also releases of reactive oxidative species, which then lead to the formation of anti-angiogenic factors, which will further aggregate preeclampsia. So with this, we can see an association with regards to how pathophysiologically it works. We can actually utilize this marker, which is actually widely available in Malaysia with respect to, in fact, our clinic kesihatan, our healthcare clinics all around Malaysia. The cost of a single test of uric acid is just RM2.80. Just imagine how good this marker can actually be for the benefit of us. All right, next slide. So my study is very simple. It's a retrospective study. So what do I want to do? I want to actually study the effects of uric acid, elevated levels of uric acid in third trimester of pregnancy to predict preeclampsia. So what we do between 2016 and 2018, those who have delivered between 2016 and 2018 in our setting and have fulfilled the inclusion criteria and doesn't have any of the exclusion criteria and developed adverse pregnancy outcomes. And they have uric acid taken in the third trimester of pregnancy. So basically, I want to see these patients' levels of uric acid in the third trimester of pregnancy that actually develop APOs. Now we see what are their levels and see whether there's any correlation or not between their uric acid levels and the development of preeclampsia. So we use a value of actually 309 micromoles per liter to assess sensitivity and specificity in actually predicting preeclampsia, based on a study by Bellomo et al., who actually did a similar study in Verona, Italy, where he found that this level of 309 micromoles per liter confers very good sensitivity of about 84% sensitivity of 84% and sensitivity of 90%, with ROC, area under the curve, of about 0.955. As a result of that, we would like to see whether in the Malaysian setting, would this apply to our setting so we can actually utilize it in every healthcare centers. So this is the results that we found. So based on our sample collection, we got 374 participants, and among that, 113 actually developed preeclampsia. So upon doing this, we can see that the p-value is actually less than 0.001. And upon doing ROC curve, we can actually see that by means of uric acid, as the level increases, the area under the curve is 0.713. And the sensitivity and specificity for the marker, which is at 309 micromole per liter, has a sensitivity of 80.5% and a specificity of 46.4%. Now, with regards to this, the discussion with regards to this, so what can we see from the chi-square test? The p-value is less than 0.001. So uric acid values in the third trimester are significant in prediction of preeclampsia. So in other words, what can we say? The null hypothesis can be rejected that 309 micromoles per liter is not associated with the development of preeclampsia. Therefore, we accept the alternative hypothesis where 309 micromoles per liter and above is a good cutoff point for the development of preeclampsia. So from the ROC curve itself, we can see 309 micromoles per liter of uric acid levels has high sensitivity despite moderate specificity. So this is a good screening marker as compared to other levels, okay? So other studies that have been conducted there, as of now, there is no official consensus on the normal reference ranges of uric acid levels in pregnancy. Even in our setting, basically, we've traditionally been used in HCTM, where the weeks of gestation multiply by 10 as the upper limit of uric acid, but then that has not been any official consensus with regards to that. Other studies actually focus on values during the first and second trimester. So they develop probably a cutoff point during the first and second trimester. But what if the patients actually have normal values below the first and second trimester cutoff values? So in the third trimester, we have no cutoff values there, okay? So other studies have also shown that variation in dietary habits can also play a role as well. That is the reason why in future studies, I would like to actually encourage people to do a more multi-centric study so we can actually have a clear view and a better results with regards to uric acid being used for the determination of preeclampsia. So my conclusion is I would like to conclude that serum uric acid levels in third trimester of pregnancy with the cutoff value of 309 micromoles per liter is a moderate predictor for preeclampsia. So all in all, I would like to implore all healthcare providers out there to actually utilize this test, which is just RM2.80, so we can reduce the mortality and morbidity as well as the burden of cost to our health ministry. With regards to basically with us currently having the COVID and whatnot, so our budget have been significantly reduced. So having better health is also in line with the third goal of the developmental goals, United Nations 17 developmental goals, which is actually to provide better health for everyone. With that, I conclude. Thank you.
Okay, thank you, Asfa. So I would like to open for question and answer session.
Dr. Asfa, yeah?
Yeah.
So you say this is a retrospective study.
Yes.
Yes. So how does that work? So you have these patients who have delivered between 2016 to 2019.
Okay.
And then you took their serum uric acid when they become pregnant again?
No.
A different pregnancy or what?
Basically, 2016 to 2018, these are patients that have delivered in our setting. And then I find among them who actually develop adverse pregnancy outcomes, which includes preeclampsia.
Preeclampsia, okay.
So from then, I look back and see what are the uric acid levels when it was taken.
So the uric acid was taken routinely?
The uric acid level was already taken in the when they were admitted, basically, at that time.
And the reason for that uric acid test was what again?
The thing is, as of now, we see some association of uric acid with adverse pregnancy outcomes. But the thing is, we don't have any clear cut-off values. So as a result, a lot of centers have just routinely taken levels of uric acid, but they don't have any specific reference range to refer to. So usually we just take it as part of the admission with regards to that.
So measuring uric acid level is already accepted as a way to predict preeclampsia. Is that what?
It's not fully. Some studies have nullified this. So basically, it depends on the center. Some centers prefer to utilize uric acid. Some centers see that uric acid is not a significant marker because they cannot relate to any reference range. They cannot relate to any cutoff value. So basically, some centers just take it for the sake of
taking it
viewing
without using it. Okay, all right. So these patients that had uric acid levels were taken in each trimester or only in the third trimester?
Okay, I screened for patients that took it in the third trimester only in line to my study.
But the natural, the common practice in the clinic is that do they take it in the only third trimester or each trimester?
Uric acid is not taken in the earlier trimesters. Actually, it's not common practice.
Okay. Okay. So if you were to do this study again, what would be a better design to give a more valid answer? Because when you compare your study with previous studies, they found specificity to be between 80-something% and your specificity is only 40-something%. Is that right?
Yes, that's correct.
Yeah. And because your conclusion is you say something along the line of this is cheaper and it should be used and blah blah blah, but then if you find something which is moderately predictive and there's a risk of giving false positive and false negative results, and therefore it affects your management of these patients. So that's not just cheap, but that's also dangerous. Do you agree?
Okay. What I would say, I have a different view because it's a moderate predictor. So at least if a patient actually reaches 309 micromoles per liter, the clinician can actually be more alert and more aware to the possibility of actually these patients developing preeclampsia. So as a result, it can just be a marker for us to be prepared. Because the thing is, sometimes what's important is basically with regards to pregnancy in Malaysia, 10 to 15% actually do not actually do their bookings. So if a patient suddenly comes in during the third trimester, we have no baseline investigations for the patient. So at least if we have taken uric acid levels, then we would know, okay, this patient probably this patient's uric acid is maybe 320. So we can actually be more alert and prepared because we have no data with regards to the patient. Since the patient did not do any booking with regard to that.
Dr. Asfa
Yeah.
Okay, I might have missed yang tadi tu. You punya pathophysiology with regards to this uric acid and preeclampsia. Macam mana tadi?
So basically, it is postulated that high levels of uric acid will induce endothelial dysfunction. So as a result of that, it will actually decrease the nitric oxide production, therefore, which will affect the trophoblastic invasion, or in other words, the placental implantation. So, and
So
at
the current
same time,
standard, the current
Sorry?
method of diagnosing, the current method of predicting preeclampsia is by protein.
But protein is
What's
somewhat a
current method used?
requirement. Basically, preeclampsia, you need to have proteinuria to be considered as preeclampsia. But as of
So
now,
the current measurement is protein kan? In the urine.
protein, yes. Protein in the urine, yes. Protein is traditionally used for diagnosing preeclampsia, because without proteinuria, there will just be pregnancy-induced hypertension or gestational hypertension. So, but as of now, the latest, they say that with or without proteinuria can also be preeclampsia, as long as there's a significant end organ dysfunction detected in the patient.
So did you actually
Specific
look
criteria
through
with
because the current standard is using protein, betul?
previously pun dah guna protein.
Okay. So did you look into into like correlation between this and protein? How, because you collected retrospective study, protein is a standard one that we use. Is there any data of your current study?
I didn't look at the protein levels. I just ensure that the patient has been diagnosed with preeclampsia, fulfilled the criteria of actually being diagnosed as preeclampsia, and I take the patient as being preeclamptic. With regards to the levels of proteinuria, I did not look into that. I'm sorry. I will probably add that into my research in the future.
All right. Okay. Thank you.
Okay, thank you, bro.
So thank you, Dr. Azfar. I think that will be our last. Dr. Azfar is our last presenter for today. So
thank you.
So I would like to thank the judges for today. Professor Madya Dr. Nani Halina from surgery, and also Professor Madya Dr. Nur Shamsiah Madin from ophthalmology department. So thank you for the presenters too, and also the participants. So actually, we will announce the winners. There will be 3 winners from this session in 5 minutes time. Okay. So give time for us to count the marks. Okay. So it's now the time to announce the winners for oral presentation for this clinical section. So we start with the third place. Okay. So this presenter present on the topic of sex determination from measurements of the first lumbar vertebra by computed tomography in the Malaysian population. So the third winner is Afiana Rohmani from medical. So now we go to second place, runner up. So the topic for this presenter is prognostic value of high sensitivity cardiac troponin I levels in patients with suspected acute coronary syndrome. So the winner is Dr. Arlizan Baizura binti Arifin from pathology department. Okay. So the winner for this clinical category, so the topic of the research is serum ferritin and MDA levels in type 2 diabetes mellitus patients, pre-diabetes and non-diabetes. So the winner is Dr. Nur Shahirah binti Saleh. So congratulations to all the winners. Okay, so the secretariat will contact you in terms of the prize giving and so on. Okay, thank you. So we will end our session here. Okay, so congrats to all the winners, and of course thank you to the judges and also the participants.
Let's say zoom up.